Hey guys, can you see my screen?
Yes, we can.
Okay, thank you. Okay, so
You're welcome.
thank you. Okay, so yesterday we left at distal convoluted tubule. So we discussed the physiology of distal convoluted tubule, and so from today, we are going to be starting from the collecting duct, right? So we are going to be starting today from the collecting duct, right, or the collecting tubule also, right? Now, for the collecting tubule, the main thing that is absorbed here at the collecting tubule is the sodium, right? So, collecting tubule is the main point that regulates sodium. And here the sodium is absorbed for two things. One is potassium, another is the hydrogen, right? And this thing is regulated by aldosterone, right? So if someone asks you where does aldosterone act in the kidney, right? So the main point is going to be collecting tubules, right? So what is the aldosterone going to do, right? The aldosterone is going to do one thing, right? The aldosterone is going to take potassium, sodium back into the blood, right? So if this is the cell, it's gonna take sodium back into the blood, right? And it's gonna take potassium back here, right? Now, why does this matter? This matter because ultimately it is gonna cause hypokalemia. It's gonna reduce the potassium ions, right? And at the same time, it's gonna increase the sodium ions in the body, right? At the same time, it's gonna cause hydrogen to be exchanged as well for sodium, right? It's gonna cause hydrogen to be exchanged as well for the sodium, and when that happens, you are gonna get metabolic alkalosis, right? So again, alcohol. Remember this thing: aldosterone leads to metabolic alkalosis and hypokalemia, right? Now we have a channel here which lets the sodium inside the cell. Right? We have a channel here that is letting sodium go inside the cell. So this is the channel, and this is gonna let the sodium to go inside the cell, right? This channel is known as the ENaC channel, right? And we have a special drug which is known as the amyloid, right? This is the amyloid or triamterene that is going to act at this point, right? So amyloride and triamterene are going to act on these channel, right? And then it's going to cause the sodium to remain in the urine, and as a result, there is going to be diuresis. Remember, I have told you earlier, whenever we want to cause diuresis, whenever we want to reduce sodium from the urine, we want to remove more water from the body. What do? We take sodium with us in the urine, right? We take the sodium with us in the urine, and when sodium goes in the urine, water follows it. So our main goal in diuresis is to prevent sodium from getting reabsorbed. So this is another way through which we can do that. Now, again, if this is the principal cells, right? So there are two cells. If this is the principal cell of the collecting tubule, right? Here another thing can happen, right? What is that thing? ADH is going to act here as well, right? ADH is going to act here as well, and it's going to act on the V2 receptors, right? So these are the small things. So if you see at the diagram here, you're going to see the V2 receptors there, right? It's going to act on the V2 receptors. It's going to insert the aquaporins here, right? It's going to insert the aquaporins here, right? And when the aquaporins get inserted here, you are going to get water reabsorption, right? So it's going to act here. It's gonna insert the aquaporins here, right? And when aquaporins get absorbed, you are gonna get water reabsorption. So second thing that is gonna happen is this area, right? Now, how does aldosterone act? This is again written here, right? So basically, aldosterone again acts on is a steroid hormone. So it's gonna go to the nucleus. It's gonna increase the transcription. So it increases the messenger RNA formation, right? And as a result, it's gonna increase the proteins that are required for transport. So it's gonna increase two protein. One is the ENaC channel, and second is this transporter, right? So this thing is gonna increase, right? So this is known as the sodium potassium pump. Right? The second thing is known as the ENaC, right? So we have these two things. Now, at the same time, in the collecting tubules, we have another cell which is known as the alpha cell, right? We have the alpha cell, we have the beta cell, right? Now we have these two cells. What are these two cells going to do? Right? So alpha cell is going to carry H positive here, right? This is the main role of alpha cell, right? And what is the beta cell going to do? Beta cell is going to do the reverse. It's going to cause H positive to go back to the blood, right? So now why do we have these two cells? So we have the alpha cell to to cause alkalosis, right? A for alpha, A for alkalosis. And right, so and B is gonna be for the B is the bad cell, right? Why? Because B stands for beta cell and AD stands for acidosis, right? So B stands for acidosis, right? So these cells are the bad cells, and these bad cells are gonna cause acidosis in the body by absorbing more water, right? So keep these things in your mind, right? So these are all the things that are gonna happen here, right? This there sodium here, water reabsorption is gonna occur, right? Here sodium reabsorption is gonna occur, and how is that gonna occur? So aldosterone is gonna act. It's gonna increase the production of sodium potassium pump. At the same time, it's gonna increase the production of ENAC channels, right? And then H positive secretion or absorption both can occur here. It depends on which cells are being used, whether these are the alpha cells or the beta cells that are gonna get used. Okay. Any questions till now? Okay. The next topic that we are gonna do is the renal tubular defects. All right. So we are gonna do the renal tubular defects because these are just related to these things, right? So the first renal tubular defect that we are gonna do is Fanconi syndrome. Right. So what is Fanconi syndrome? So Fanconi syndrome is pretty easy, right? Fanconi syndrome is very easy. What is gonna happen in case of Fanconi syndrome is the proximal convoluted tubule is not gonna work, right? So proximal convoluted tubule is not gonna work. Now when proximal convoluted tubule is not gonna work, right? No reabsorption is gonna occur at proximal convoluted tubule. So what are the substances that are absorbed here at the proximal convoluted tubule, guys? What are the substances?
Sodium and glucose,
Yes, sodium,
and
glucose. What else?
potassium too.
Two or
100%
yes.
glucose, 100% ammonia.
What
Amino
I
else?
said
acid.
phosphate.
Ammonia.
Yes. Yes, so amino, so you have to remember these by hearts, right? You have to remember what steps are absorbed at what point, right? And phosphate as well. Remember, PTH was causing phosphate to not get absorbed, right? So if the absorbing formula is opposite, the amino acids, glucose, sodium, and phosphate, and bicarbonate as well. So we were absorbing bicarbonate with the help of carbonic anhydrase there, right? So all of these things are not gonna get absorbed, right? And what is gonna happen then, right? So in Fanconi syndrome, the thing that is going to happen is since bicarbonate are going to get lost, right? There is going to be acidosis, right? Potassium was being absorbed here, like you told me. So when potassium is not absorbed, you are going to get hypokalemia, right? You are going to get hypophosphatemia because phosphate is not being absorbed, right? You're going to get hypophosphatemia, right? Because the phosphate is not being absorbed at the same time as well, right? So these are all of the things that are gonna happen. There is gonna be acidosis, right? There is gonna be hyperphosphatemia. There is gonna be hypokalemia. Now there are a lot of things that can lead to these things, right? Now, obviously, the main thing that is the main problem that occurs here is the hyperphosphatemia. Why is this thing so important? This thing is so important, right? Because renal tubular acidosis usually happens in children, right? This is gonna happen in children, right? There are a lot of reasons for it, right? So this is gonna happen in children, and when this thing is gonna happen, when you do not have phosphate, so you need phosphate along with calcium to form the bonds, right? You need these for the mineralization of bond, right? So when you do not have these phosphate, the mineralization of bonds cannot occur, right? And when the mineralization of bonds cannot occur, you're not gonna get weak bonds, right? The bonds are gonna be weak, which is gonna be known as the rickets. So you're gonna have rickets in children because of this thing. Now the next thing is the Bartter syndrome, right? So, okay, so we can skip Bartter because we're ignoring the thick ascending. I'm gonna do the thick ascending after it. The next is the Gentleman, right? The Gentleman is very easy, right? Remember
Dr. Moss,
this.
can you
I,
please
I
spell how
have a question.
acidosis?
What?
I have a question. Can you just go over the Fanconi syndrome? What do we have to take out of it in the Fanconi syndrome?
Okay, okay. And what was the other question?
Just the mechanism of acidosis.
What? I did not get your point. Sorry. So sorry.
How the acidosis occurs.
Okay.
Metabolic.
So acidosis is occurring. So first of all, let me repeat the whole of the whole Fanconi syndrome, right? So what is Fanconi syndrome? So if you remember that we did the proximal convoluted tubule yesterday, right? And in proximal convoluted tubule, what were the stuffs that were being reabsorbed? So sodium was being reabsorbed, glucose was being reabsorbed, right? The next thing that was being reabsorbed was the HCO3, right? So the bicarbonate ion. So when bicarbonate ion is high, it's a mechanism, right? When bicarbonate, remember these things. When bicarbonate ions are high, you are gonna get alkalosis, right? Because bicarbonate is an alkali, right? When bicarbonate ions are high, you are gonna get metabolic alkalosis. When bicarbonate ions are lost, or when bicarbonate ions are low, you are gonna get metabolic acidosis, right? Again, if bicarbonate are high, you are gonna get alkalosis. If bicarbonate are low, you are gonna get acidosis, right? So since bicarbonate is not getting reabsorbed here, right, the bicarbonate ions are all going to be lost in the urine. So you're going to get acidosis, right? So amino acids are being reabsorbed here as well. So amino acids are being glucose is being reabsorbed, HCO3 are being reabsorbed, phosphate is being reabsorbed, potassium is being reabsorbed, right? So when there is Fanconi syndrome, you are going to get loss of glucose, amino acids, bicarbonate, phosphate, and potassium, right? All of these things are going to get lost in the urine, right? All of again, I'm repeating, all of these things are going to get lost in the urine, right? And when phosphate gets lost in the urine, you cannot make any more bones, right? So no more bone is going to get made, right? So no more bone is going to get made. And when no more bone is going to get made, you are going to get rickets, right? You are going to get osteopenia, you are going to get rickets, you are going to get bone problems. And especially this is happening, and this is going to happen in the kids, right? Any questions regarding these?
No, we got it now. Thank you.
Oh, you're welcome. Now, so these renal tubular defects are very easy, but people make it very hard. So if you remember it with the nephron physiology, this is gonna be easy, right? So now, what was the main thing that was happening at the distal convoluted tubule? What was the main thing? Number one thing.
Sodium chloride reabsorption.
Yes, so sodium chloride absorption was occurring, right? There was a channel that was absorbing sodium chloride. So in Gentleman syndrome, sodium chloride transporter at the DCT is gonna be gone, right? So in Gentleman, the sodium chloride transporter is gonna get blocked, right? It's not gonna work. So it's gonna be just like thiazide diuretic use, right? It's just gonna be like thiazide diuretic use, right? And I have already told you when this channel is not gonna work, what metabolic abnormalities are you gonna get, right? What are the metabolic abnormalities? Can anyone tell me? Because these metabolic abnormalities are very important.
Metabolic alkalosis.
Hypernatremia,
So first of all, hyponatremia, right?
low blood
Or
pressure,
yes, so you're gonna get hyponatremia, right? At the same time, you're gonna get metabolic alkalosis as well, right? And you are gonna get the main no, so there is gonna be hyper. Okay, so metabolic alkalosis as well, right? And the next thing is that you're gonna get hypokalemia as well, right? So this causes hypokalemia. Right. So you're gonna get metabolic alkalosis, hypokalemia, hyponatremia, right? So these are the main things that you're gonna have due to Gentleman syndrome, right? This is very easy, right? Gentleman syndrome is due to effect of NaCl, NaCl reabsorption in the distal convoluted tubule. So any questions regarding this, guys? How is it metabolic alkalosis? All right. Okay. Okay, so guys, are you with me here? Let me explain. How does Gentleman syndrome causes metabolic alkalosis? Right. So how does Gentleman syndrome causes metabolic alkalosis? Right, or why? How? So Gentleman syndrome is just similar to thiazide diuretic use. Similarly, whenever you're using furosemide, so remember furosemide act on this thing, right? It's one sodium, one potassium, two chloride transporter. So it blocks the absorption of sodium, right? Again, here sodium absorption is going to be blocked and we are going to get diuretics. Why is this thing important? This thing is important, right? So if you look at the nephron, right? So let me draw the nephron once again, right? So if you look at the nephron, right, we are going to see that this is the nephron, right? Right, guys. So if this is the nephron, this is the proximal convoluted tubule. This is the descending loop of Henle, right? This is the atric ascending loop of Henle, right? This is the distal convoluted tubule, and this is the collecting duct, right? So what if I tell you a patient is having a patient is having Gentleman syndrome, right? Will his sodium levels be high or will his sodium levels be low? What do you think?
No.
I think it's
Low.
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 So this low. So
Mm.
sodium levels are going to be low. So sodium levels are going to be very low, right? So when sodium levels are going to be very low, what hormone is going to get activated? Like what hormone gets activated when sodium levels are low?
Aldosterone.
Yes.
Aldosterone.
Aldosterone.
Yes. So aldosterone is going to get activated, right? Now, when aldosterone gets activated, what are the two effects that aldosterone have in the kidney? Can anyone tell me? I have just told you about those.
Hypokalemia and metabolic alkalosis.
Yes, hypokalemia and metabolic alkalosis. That is why how Gentleman syndrome causes metabolic alkalosis and hypokalemia, right? This is how Gentleman syndrome is going to lead to metabolic alkalosis, right? Because it's going to this aldosterone is going to go to the collecting duct, right? It's going to go to the collecting duct, and what it's going to cause? This is going to cause hydrogen to move here, right? This is going to cause hydrogen to move outwards, right? And at the same time, it's going to cause sodium to move here, right? And potassium to move here as well, right? So these two things are going to happen, right? And when these two things are going to happen, you are going to get metabolic alkalosis and hypokalemia, right? So now what is Liddle syndrome? So before Liddle, let's go a very easy one, which is the same syndrome, right? So the name is same. So it stands for syndrome of inappropriate mineralocorticoid access, right? Now, what is this thing, right? So basically, aldosterone is needed to activate the aldosterone receptors that are present. So aldosterone is needed to activate the aldosterone receptors that are present in the collecting tubule, right? Now we have a hormone which is known as the 11 beta HSG, right? What is this HSG hormone gonna do? This 11 beta HSD is gonna convert. We have another hormone which is the cortisol, right? So it is gonna convert cortisol to cortisol. Why is this thing important? This is important because cortisol can also act on the aldosterone receptors, right? Cortisol can also activate the aldosterone receptors. But if it gets converted to cortisol, then cortisol won't activate the aldosterone receptor and it will only act on the cortisol receptors, right? So this thing is important. We need the cortisone. We need the 11 beta hydroxysteroid dehydrogenase, which is the 11 beta HSD. 11 beta hydroxysteroid dehydrogenase is going to block the conversion of cortisol to cortisol. Right? It's going to block the conversion of cortisol to cortisol. And when this conversion is going to get blocked, right, you're not going to get cortisol activity on the aldosterone receptor. So what if I say to you that due to some reason this 11 beta hydroxysteroid dehydrogenase is not working anymore? Right? So what if this hormone or what if this enzyme is not working anymore? What do you think is going to happen in the patient? Anyone? So no. So remember,
Hy-
cortisol has two effects, right? It's gonna
Hypercal.
it's gonna absorb, it's gonna block the function of cortisol on the aldosterone receptors. It's not gonna affect the effect of cortisol on the cortisol receptors. The effect of cortisol on the cortisol receptors are gonna stay the same, right? It's only gonna affect the other receptors, right? Or on the aldosterone receptors. So what is gonna happen? So think what is gonna happen if this 11 beta hydroxysteroid or dehydrogenase does not work.
Hyponatremia and hyperkalemia.
Yes. So basically, what is going to happen is that okay. So let me make a diagram for you here, guys. Right. So basically, if this was the collecting tubule, right? If this was the collecting tubule, right? What is going to happen is that normally two things can act here. So one is aldosterone, right? So if this is the aldosterone receptor, aldosterone can act here, right? So first thing is that aldosterone can act here. Along with aldosterone, the other thing that can act here is the cortisol, right? And when cortisol acts here, it has the same function as that of aldosterone, right? So what functions do aldosterone have at this point as a collecting tubule?
Sodium deabsorption.
Yes. So sodium reabsorption. Any other thing? What are the two metabolic other effects that it's gonna have? What are the two other things?
Potassium
Hypokalemia.
excretion.
Yes, so it's gonna cause hypokalemia, right? And what about acid-base balance?
Metabolic alkalosis.
Yes, so
Cirrhosis.
alkalosis. So what if I say to you that this cortisol is being let? So this cortisol usually, so we have a policeman here, and the policeman in is 11 beta hydroxysteroid dehydrogenase. Whenever the cortisol comes here and cortisol tries to activate this receptor, this 11 beta hydroxysteroid dehydrogenase comes here and it asks the cortisol not to act here anymore, right? So this is the National Guard, right? This is the National Guard. This is the army which does not allow the cortisol to act here, right? So it causes the cortisol not to act here. It blocks the cortisol, right? So the cortisol is gonna get blocked, right? The cortisol is gonna get blocked, right? Right. The cortisol. So basically, it's gonna get blocked, and when it's gonna get blocked, what is gonna happen is that what if this cortisol gets blocked again? You're gonna have the same thing, right? The cortisol is not going to work. This is a normal function because we only want aldosterone to work here and not the cortisol. But if what if due to some reasons this 11 beta hydroxysteroid or dehydrogenase does not work anymore, right? What is going to happen is that the cortisol levels in the collecting tubules are going to increase, right? And we are going to have a mimicking effect of aldosterone, right? We are going to check the aldosterone levels in the body, and the aldosterone levels are going to be normal, but the patient is going to have hyponatremia, and the patient is going to have all of those things, right? The patient is going to have hyponatremia, and the patient is going to have all of those things, right? Is this clear, guys?
Can you repeat it, please?
Okay, just give me 1 minute. Just give me 1 minute. Okay, so what I was saying is the fact that okay, so let me repeat it once again. Right? Basically, whenever we are having aldosterone excess, we can easily see whenever we are having aldosterone excess, it's very easy to see if we are having aldosterone effect. Why? Because we can just do a test, right? And in that test, we can just see the aldosterone levels. And if the aldosterone levels are increased, we can see that the patient is having increased aldosterone levels, and at the same time, the patient is going to have hypokalemia and metabolic alkalosis, right? So now, what if a person comes to you and you check the patient's blood, right? The patient is having hypokalemia, right? There's going to be hypokalemia in the patient, right? Right, and at the same time, the patient is going to have the patient is going to have metabolic alkalosis as well, right? The patient is going to have here metabolic alkalosis as well. There is going to be metabolic alkalosis that is going to be present here as well, right? And now you check the aldosterone levels, right? You look at the aldosterone levels, and the aldosterone levels are normal, right? The aldosterone levels are going to be normal. They are not going to be increased. Now they give you a question that a scientist is trying to work on a disease, and the disease, the scientist marks the aldosterone, right? And the aldosterone levels are normal, right? But the aldosterone receptors in the kidney are being constantly being activated, right? So what is the most likely cause of these activation of the aldosterone receptors? This is the question they can give you, right? This is the way they can give you. How is this thing activating? So this thing is being activated by a very simple way, right? There is another hormone which is known as the cortisol, right? The cortisol can also get bound here, right? And when the cortisol gets bound here, it's going to activate these receptors, right? It's going to activate these receptors, right? And we have a thing which is known as 11 beta hydroxysteroid dehydrogenase that blocks the cortisol to act here. It blocks the cortisol to act here, right? But in this disease, in this hereditary problem, 11 beta hydroxysteroid dehydrogenase is not going to work. So all of the cortisol is going to activate the aldosterone receptors, and as a result, you are going to get excess of you. It's going to look like you are having an excess of aldosterone, but in reality, there won't be any excess of aldosterone, right? This is the question. This is the way they are going to give you. They are going to say that there's an excess like syndrome, and there are metabolic abnormalities that are very similar to excess of aldosterone. But when you check the aldosterone levels, they are normal, right? Now they are going to ask you what is the most likely diagnosis? Why is this thing happening, right? Is this clear now? Okay, guys, any questions regarding this thing? Okay. Now, why this thing is occurring? So this thing is hereditary, and we have another thing which is known as the glyceretinic acid, right? So we have the glyceretinic acid, right? We have the glyceretinic acid, right? Which is present in licorice, right? So this thing is present in the licorice, right? And this thing is gonna cause this syndrome, right? This thing is gonna lead to syndrome of inappropriate mineralocorticoid, right? Is this clear, guys? Now the last one is very easy.
Yes.
The last one is very easy. What is, so what is going to happen in the last one? So this is known as the Liddle syndrome, right? So Liddle syndrome is gonna affect this thing, right? So this was the ENaC channel, right? This was the ENaC channel, right? And what is gonna happen is that it's gonna increase the number of ENaC channels, right? In Liddle syndrome, the number of ENaC channels are gonna increase, right? And when the ENaC channels are gonna increase, you're gonna get the same thing again. The sodium levels are going to be increased, right? The potassium levels are going to be decreased, and the bicarbonate or levels are again going to decrease. So there's going to be metabolic alkalosis, right? So again, you're going to have symptoms of aldosterone excess, right? But when you are going to look at the patient's picture, when you're going to do an examination, when you're going to do a test of the patients, you are going to see that the aldosterone levels are normal, right? They are normal or they are low. Right. Now, how can we treat this thing? In order to treat this thing, we have to block the ENaC channels. And what is the drug that blocks the ENaC channel, guys? What is the drug that blocks ENaC channels?
Amyloid.
Right. We are right. It's gonna block the ENaC channel. So the treatment is very simple, right? We are gonna give amyloid. And what are the drugs that block the aldosterone receptor? Aldosterone receptors are blocked by two drugs. So aldosterone receptors are gonna get blocked by spironolactone, right? Right, so it's gonna get blocked by spironolactone and eplerenone, right? So these are the two ones. Spironolactone and eplerenone are blocking the aldosterone receptors. So if someone asks you the treatment or the mechanism of treatment of the symptom of inappropriate mineralocorticoid access, so in that you can get spironolactone and eplerenone. Because as soon as you give spironolactone or eplerenone, these receptors which were being activated by cortisol, they are not going to get activated anymore. Okay. Now let me see the questions. Yes, so whenever there is adrenal hyperplasia or there is Cushing's, you are gonna get these metabolic alkalosis symptoms as well, right? You're gonna get metabolic alkalosis and those as well, right? So you are exactly right. Whenever cortisol is high, you are gonna get these symptoms. Or the other ways that you can get these symptoms is that sometimes 11 beta hydroxysteroid dehydrogenase is not gonna work, and you are gonna have all of these symptoms, right? And so everything clear now, guys?
Yes.
Okay. If you have any questions regarding these tubular defects, you can ask me. If not, then we are gonna move forward. Okay, so the next system is the renin-angiotensin system or the RAS system that we are gonna do today. Right? So we have the RAS system that we are gonna do today. Now, what is the RAS? What is the renin-angiotensin system? So this system is formed by the kidneys, right? So this is a very important system by the kidneys. And why is this system in place, right? So this system is in place to basically reduce. So we have the renin-angiotensin system, and this kidney system is to increase the absorption of water in the body, right, and to increase the absorption of sodium in the body. We have already done almost all the things in this system. We are just reviewing. So if you start reviewing it, right, first of all, where what are the renin-angiotensin system receptors, or where are the points that where the body sees that we need to activate the renin-angiotensin system? That is the first thing that can be asked to you in the exam, right? What are those area where the renin-angiotensin system is going to get activated, and it's going to sense that we need to activate the renin-angiotensin system? So that point is the macula densa, right? So that thing is the macula densa, and that macula densa is present in the distal convoluted tubule. Right. So macula densa is going to see this, right? The macula densa is attached to another structure that is attached to the afferent arteriole like this, right? So the distal convoluted tubule is attached to the afferent arteriole like this, right? And what is that structure? That structure is the juxtaglomerular apparatus, right? Now, juxtaglomerular apparatus is going to secrete renin, right? So the first thing in this system is renin. So whenever you have low renal pressure, whenever the renal plasma flow is reduced, whenever the renal blood flow is used, this is going to be detected by macula densa as well as the afferent arteriole, especially the juxtaglomerular apparatus. And what is going to happen is that, right? So by so when fuel pressure is low, sympathetic system is being activated. When is the sympathetic system activated? The sympathetic system is activated whenever you are having a fight or flight response or any bad. At the same time, if the NaCl delivery, the macula densa is less, right? So if macula densa are getting less amount of sodium, the macula densa is going to have the juxtaglomerular
Dr.
apparatus
Moaz,
is.
I can't really hear you. Your voice is breaking. I don't
Yeah,
know for other
your
people,
voice is
but for
breaking
me, I
up,
can't hear
doctor.
you at all.
Okay,
And
Yes,
you
from
told
when you
okay, just give
started
me
RAS,
one second.
from when you started the RAS system, I didn't hear a
Okay,
single thing.
yeah, and
Yeah,
can you
okay,
your
okay, wait a
voice is
second.
breaking up a lot. And also, can you go a little slowly if you can do that, doctor? Thank you.
yeah.
No, like from RAS, I didn't understand anything. Like I didn't hear anything.
Okay, guys, can you hear me clearly now?
Also,
Yeah,
can you
this
go
is
slowly, also,
better.
doctor? Yeah, can you go
It's better
slowly, also?
now.
Thank you.
Okay, I'll
Yeah.
go slowly, right? So the first thing that now we are going to do is the renin-angiotensin-aldosterone system or the RAS system, right? Why is this RAS system important? What is the function of this RAS system? This is the first thing that we are going to know, right? So RAS system has three main functions, right? It's gonna activate whenever the body thinks that we are having less amount of water, right? We are having less amount of fluid in the body, right? The fluid is being lost, the blood pressure is low, the sodium is low, right? Or the kidneys are not functioning properly, right? Whenever these all of these things are going to be detected by the kidneys, then the body is going to activate the RAS system or the renin angiotensin aldosterone system, right? So it's going to activate this system as soon as these things happen, right? So this is how renin angiotensin system gets activated, right? This is the important thing. You have to keep this thing in your mind, right? Now, how does the renin angiotensin system gets activated? What detects that the renin angiotensin system is going to get activated? So three things, right? The number one is macula densa. Macula densa is a structure that is present in the distal convoluted tubule. And when macula densa or the distal convoluted tubule gets less amount of sodium, the macula densa activates the renin-angiotensin system by secreting renin with the help of juxtaglomerular cells. So it asks the juxtaglomerular cell, which is present here, to secrete renin. At the same time, afferent arterioles detect the amount of renal blood that is coming to the renal arteries, right? Afferent arteriole sees how much blood is coming into the kidney. If less amount of blood is coming into the kidney, what is going to happen is that renin-angiotensin system again is going to get activated, right? And these juxtaglomerular cells are going to be activating as well, right? As these juxtaglomerular cell is going to get activated as well. Right, this is going to activate it again, and this is going to secrete renin, right? This is going to secrete renin again, okay? The renin is going to get secreted once more. So keep this thing in mind. So renin is going to, thirdly, if you are going to have sympathetic tone activated, so if you are going to have sympathetic system activated, juxtaglomerular cells are going to have the beta 1 receptors, right? So we're going to have the beta 1 receptors that are present here on the juxtaglomerular cells, and this is going to get activated, right? So when the beta 1 receptors get activated on the juxtaglomerular cells, we are going to have again the secretion of renin, right? Now what is this renin going to do, right? Now this renin has a lot of important functions, right? What is the important function? So our kidney forms an enzyme which is not, our liver forms an enzyme which is known as an angiotensinogen, right? So juxtaglomerular cell is going to form the renin, and this is the angiotensinogen, right? It's going to convert the angiotensinogen into the angiotensin 1, right? This angiotensin is gonna get converted into the angiotensin 1, right? Now this angiotensin 1 is gonna go to the to the lungs, right? Where you have another enzyme which is known as the ACE, which is angiotensin converting enzyme, right? And this is where from the drugs ACE inhibitors come from. So ACE inhibitors act on these drugs, right? So where here we are gonna have the ACE, right? So the ACE inhibitors are gonna increase the conversion of angiotensin 1 to angiotensin 2, right? Now, what is the angiotensin 2 gonna do? This is the most important thing, right? Angiotensin 2 is gonna affect a lot of things, right? First of all, it's gonna increase the absorption. So these are all the functions of angiotensin, right? First of all, angiotensin is gonna act on the blood vessels. It's gonna increase the BP. It's gonna cause vasoconstriction, right? Then the angiotensin is gonna so nice. Second thing is that angiotensin is gonna block the efferent arteriole, right? And it's gonna increase the GFR. We've already discussed whenever the GFR, whenever the efferent arteriole gets constricted, how the GFR is gonna increase, right? Then it's gonna go to the proximal convoluted tubule, right? And it's gonna increase the absorption of sodium, bicarbonate, and water, right? Now it's gonna go to the aldosterone. It's gonna increase the aldosterone, right? And when the aldosterone increases, it's gonna increase the absorption of sodium. It's gonna increase the secretion of potassium and secretion of H positive ions, right? So these are all of the things that we have done, right? There's these things are gonna do, right? It's gonna increase the increase secretion of ADH as well, right? So these are all of the things that angiotensin does, right? So angiotensin 2 is going to do all of those things. It's going to help maintain the blood volume and the blood pressure, right? Now, if we have angio, so now you worlds and NBMEs can ask you this question a lot, right? And I'm going to ask you this as well. So what if a scientist is doing an experiment and is he checking the level of angiotensin 1, 2, 3, 1, 2 angiotensinogen as well, right? So what if we give an ACE inhibitor to the patient, right? What if we give the patient ACE inhibitor? What is going to happen to the level of angiotensin 2 and angiotensin 1 and angiotensinogen?
Angiotensin 1 will stay the same, but 2 will decrease and aldosterone will decrease.
Yes, so aldosterone is going to decrease, angiotensin 2 is going to decrease, but will angiotensin 1 remain same, or it's going to increase as well? Or it's going to increase?
Increase.
It will increase. It will
Yes,
Right.
increase.
angiotensin 1 is going to increase,
Increase
angiotensinogen
because
is
there's
going to
no
increase,
conversion
right?
to two.
And
Yeah.
renin is going to increase as well, all right? This is what is going to happen, right? So basically you can see almost all of the functions that the angiotensin has, right? It has a lot of functions, and in this way, by having all of these functions, angiotensin affects our body, right? So it affects our body in such a great ways, right? Now normally this is a good thing, right? But whenever we are having heart attack, or whenever our kidney blood heart is not functioning properly, if we have these things again, in case of heart failure, what is going to happen is that the heart is going to have a difficult time. Angiotensin is going to give a difficult time to our heart, and our heart is going to stop working properly. So that is why we give the angiotensin inhibitors, right? Or we give the angiotensin receptor blockers, right? So we give these two things, and these are going to improve our mortality outcomes in case of heart failure, right? Now we have ANP and BNP. We have already discussed ANP and BNP before. They are going to be released from the atria. They are going to be released from the ventricles when the water volume is going to increase, right? They are going to smooth the vascular muscles, right? They are going to increase the GFR because they are going to increase the blood flow to the kidney, and they're going to decrease the running, right? So when this thing is going to happen, a lot more filtration is going to occur, right? When the running the RAS system is going to get deactivated, you are going to have increased amount of sodium loss in the urine, or you're going to have diuresis and natriuresis as well, right? Now aldosterone is, we have already done ADH as well. So what is ADH going to do? ADH is going to increase, is going to respond this to the serum osmolality. It's going to respond to low blood volumes, right? It's going to increase the absorption of water, right, in the collecting ducts, right? Now we have the aldosterone. We have already done how aldosterone work and what are the main mechanism, right? So basically so the main thing is that aldosterone is secreted whenever there is hyperkalemia, right? So keep this in mind. They can ask you what is the most likely mechanism of action of the aldosterone, right? What is the most likely mechanism of action of aldosterone? This is how aldosterone is going to work. It's going to work on the it's gonna work due to hyperkalemia. So whenever there is hyperkalemia, aldosterone secretion is gonna increase. Okay, guys. Any questions? Now, what is juxtaglomerular apparatus? Right, we have already discussed this. So, juxtaglomerular apparatus improve the mesangial cells. So, basically, this is part of the glomerulus. The juxtaglomerular cells, these are part of the afferent arteriole and the macula densa, right? These are the NaCl cells, right? Juxtaglomerular cells are going to secrete renin. And when do they secrete renin? When the blood pressure is low, right? When the sympathetic tone is increased, or when macula densa detects it, right? So then the renin is gonna increase, right? And the renin is gonna cause GFR increase, right? And all of these things are gonna happen, right? Okay. So anything, guys, any questions till now? Now, one important thing is that we also give beta blockers in case of heart failure, right? We also give beta blockers, and we have seen whenever we give the patients beta blocker, what is gonna happen, right? Whenever we give the patients beta blockers, the patient are again gonna have increased mortality outcomes, right? So it means whenever a patient is having heart attack, right, or whenever a patient is having any kind of heart complication, and at that time, if renin-angiotensin system gets activated a lot, you're going to get very bad outcomes for the patient, right? You're going to get very bad outcomes for the patient if a patient is having heart attack or heart failure and renin-angiotensin system is activated. So there were three ways renin-angiotensin system got activated, and one of that was the sympathetic system, right? So especially the B1 receptors, right? So if we give the patients beta blockers, or if we give the patients these blockers which are going to act on the sympathetic system, what is going to happen? The thing that is going to happen is that now the renin is not going to activate it, right? So if we give the patients beta blockers, right, the renin is not going to get secreted again. The RAF system is not going to work, right, and we are going to get very good outcomes for the patient, right? We are going to get very good outcomes for the patients, right? Okay, now any questions till now? If not, we are going to move forward. Okay, so now there are some kidney functions, right? So basically, kidney does, or not only does filtration, but it does some other kind of work as well, right? And what is that work which the kidney does? So we have to look at that thing as well, right? So what are the other things that the kidney does as well? So the first thing is that kidney secretes erythropoietin, right? The first thing is that our kidney is going to secrete the erythropoietin, right? And when the erythropoietin is going to get secreted, right, by the kidney, right? So whenever there is going to be hypoxia, erythropoietin is going to get stimulated, it's going to get secreted, and this erythropoietin is going to increase the formation of RBCs, right? So RBC formation is going to get increased, and you are going to get polycythemia. It's going to correct the anemia, right? At the same time, I've already told you how kidney works, right? Especially the proximal convoluted tubule, and it increases the absorption, or it increases the formation of vitamin D into an exhibited form, right? So remember, whenever the vitamin D comes in D without any hydroxylation, right? So vitamin D does not have any hydroxylation, right? Vitamin D does not have any hydroxylation, right? Now, first of all, the vitamin D is gonna go to the liver, right? And in the liver, vitamin D is gonna get activated to vitamin D 25 hydroxy vitamin D, right? So there is gonna be 25 hydroxylation of vitamin D. So when this is gonna happen, after that, the next thing that is gonna happen is that it's gonna go to the kidney, and in the kidney, PTH is gonna activate on the proximal convoluted tubule, and it's gonna ask the proximal convoluted tubule to convert this 125 hydroxy vitamin D to add another hydroxyl group to it, right? So it's gonna get converted to 125 hydroxy vitamin D3, right? This is what is going to happen, right? So it's going to get converted to the ultimate form, right? Now the third thing is that kidney forms prostaglandins as well that increase the renal blood flow, and we have discussed this thing again and again and again. How does NSAIDs block this prostaglandin synthesis? When this is going to get blocked, you're going to get constriction of afferent artery and GFR is going to be low. This can cause acute kidney injury. This can cause loss of function in kidney. So we can skip dopamine for now. We'll come to it later in a separate topic, right? So these are the hormones that are acting on the kidney. We have already done all of these, right? So we have done aldosterone, right? We have done ADH, right? We have done parathyroid hormone. We have done angiotensinogen, and we have done ANP as well, right? Any questions regarding these hormones, guys? Guys, can you hear me?
Yes.
Okay. So
Yes,
any
we can.
questions? Okay. So any questions regarding anything that we have done?
Do we get recorded video of this class?
Yes, yes. You're gonna get the recorded video of this class as well, right? No. So now we are left with electrolytes and acid base physiology, right? And so we are gonna do this acid base physiology and electrolytes in the pathology portion, right? So almost all, right? So because I prefer to do it with the pathology, right? Because it gets linked a lot to the pathology, right? So with that, almost all physiology is done. Right? All of the physiology is done. We have completed all of the physiology of the renal system, right? And I hope so that it's clear to you, right? If you have any questions, if you want to ask me anything specially, you can ask me in the group as well, and I would be happy to answer all of those things for you, right? I would be very happy to answer anything to you guys, right? Okay. Okay, so we'll keep our lecture till here today, right? And we're gonna start tomorrow from the pathology of the renal portion, right? And then we're gonna do the acidosis and alkalosis as well as the electrolyte abnormalities, right? Okay.
Okay.
So
Tomorrow
okay.
class, is it going to be same time as we started
Mm,
today?
yes, so it's gonna be at the same time, right? So it's gonna be at 10:30 EST, right?
Okay.
Okay. Okay, guys.
7:30
Okay.
PST for me. Okay.
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 Okay, guys. Take care. Bye bye.
Thank you
Bye.
very much, Dr. Morse.
You're welcome. You're welcome.
It's
Thank you.